all the what you might broadly call social sector, but they include not only health and education, but they also include agriculture, environment, rural development, PDS, minorities, you name it, all of that grab bag. In 2012-13, all of these put together were about 3.2% of GDP. By 2017-18 budget estimates, it was still at roughly that same figure. Okay? Now, where is that as compared to what we've been saying we need in the health sector, which is something like 2.5% coming out of all public expenditure? Now, this is, of course, it's central government budget, so it's not all of the money that's in the states and so on. Now, as compared to that, defense is more than 2% and has remained at more than 2%. Now, you can say we've got Pakistan, we've got China, we've got this and that, but the magnitudes of orders of magnitude here are such that they tell us this can't go on. Out of this kind of expenditure, even though NHM has gone up, the National Health Mission's allocation has gone up from about 22,500 crores to about 27,000 crores, but RSBY, or the national, it's not entirely clear, but the insurance assurance package actually seems to have gone down from about 1,600 crores to about 1,500 crores. Jan Aushadhi, the drugs component, last year it was only 49.7 crores. This year it's gone up to 74.6 crores. You're not going to get much by way of drugs or removal of out-of-pocket expenses problems on drugs. I could go on, but if you look at the overall picture, yes, it isn't as bad as it was last year, but it's not much better. The question is, yes, we can have strong statements in the national health policy, and I'm entirely in favor of many of those strong statements and directions. But as the Americans love to say, and I'm not sure I should even say the words here, where's the beef? We don't know where the money is that is actually going to support this health policy, whether over a 3-year period or a 5-year period or whatever else. Let me then just hark back finally, and this is my concluding comment. Gandhiji said there's enough for everyone's need, but not enough for everyone's greed. And I think that we are actually right now in the country back to exactly that situation. If we want social solidarity, we have to be able to increase taxation. There's only 3 ways that we can get a change in this financial situation. Either you increase taxes, or you go to spending much more on social determinants of health. Swachh Bharat Mission, one of the most useful ways in which the Swachh Bharat Mission could go forward is by ensuring there are toilets in primary schools, and you teach children at the primary school level to use clean toilets with available water. If you do that, those children are not going to go into open defecation. But barely 25% of our primary schools have functioning toilets. So if we we need to rethink where it is that we fundamentally need to, and that fundamentally need to focus in order really to tackle the social determinants of health. It's great that girls and boys and everybody are in primary school. Now, where are the toilets? And how will children learn to use toilets if you don't teach them in primary school. They don't have them at home. You have to teach them in school. And that's how you will get not one odd girl here who says in village X, in UP, ki main usse shaadi nahi karunga because there's no toilet in his house. That should be every girl. That should be everyone who comes to that age. And it's only then that we will create the kind of social determinant revolution that we need. And finally, the private sector's, I would say we keep talking about the private sector's role, but the private sector's responsibility has to be fundamentally recognized. The private sector cannot keep pushing and pushing and pushing for less regulation and less regulation, so that in the poorest parts of the country, we have MRIs galore and no toilets and no basic facilities for development. We must, in order for the private sector to play the correct kind of responsible role that we desperately need from the private sector at this point, they must recognize their central position in ensuring social solidarity. Thank you very much.
Thank you. Thank you so much, Geeta ji. And I think two underlining factors that come out of the discussion till now is, one is equity is a value that cannot be negotiated at any given point of time. And the second has been the term that has been used by each speaker is social solidarity. Moving from here ahead, we have with us Dr. Meera Shiva, who's going to speak to us on access to medicine, meeting the challenges. As fiscal space is running out, even time space is running out. And I hope we can be as judicious as possible in this. Ma'am, if you could come from here. Would you like to be here and speak?
So first, let me thank and then go immediately and start, because you said you wanted everything done fast. So I'm from health background, and my economics that I have learned, people's economics, how things happen in reality. Can you please move to the next one? Okay. The mic is here. So this is the universe, the SDG goals that had been mentioned. This is the 3.8. Okay, thank you. So achieve universal health coverage, including financial risk protection, access to quality healthcare services, not any little small package, quality health services, and access to safe, effective, quality and affordable essential medicines and vaccines for all. So this is the SDG goal 3.8 to which we have signed. And national health policy was also discussed just now. So to make it happen, what all needs to get done? Can you, you want me to change it? Sorry, I don't know your gadget. What do I press? It's not moving. Where do I press? Okay. Okay. I thought this was the... So if you see the tallest bar is United States, and the smallest one at the bottom is India. US model will not work for us. So this is the amount that they are spending, and the dark, sorry, it is not very clear, that the dark bit is what the government spends, and the rest is, what the people spend out of pocket. So the question is, the amount that is being budgeted for health is grossly inadequate. And if we had rich citizens, even what they pulled out from the pocket, it wouldn't be so bad. But there are big chunk that is below and around poverty line, what Dr. Srinath was saying. So sometimes they say 40 percent, some say 36, 28, whatever. But we know large number are basically poor. Okay, it's gone back. I'm pressing, but nothing is happening. Yes. You will do? So how will you know when to change? Anyway. Next? Okay. Excuse me, I'm not IT smart. And I don't think I would like to be too much, little bit, what is essential. So if you see 68, almost 70% is household out of pocket. So if it is household out of pocket, it's not free floating. So you cut on education, you cut on food, you cut on something else, and you take loan, you do many things, and especially, as was mentioned, the non-communicable diseases for which you have to take, like hypertension, diabetes, many, you to take the medicines for the rest of your life. So they're different from malaria ka course you complete and TB ka course you complete. And next one, please. So please see, sorry, there's no pointer. Just see these, 78% Orissa. So household, say, and Orissa, I'm skipping Punjab, but Rajasthan, Bihar, Madhya Pradesh, they're not particularly rich states. So if from the poor people this much is being taken out, and so they're having to pay, as with the economic growth that is being shown, that the fact that it should continue like that, that is extremely, extremely sad. Next, please. So, number of people impoverished due to out-of-pocket, health and medicine. So these are the figures for. So if you see, all of them from 1993, 94, 2004, 5 to 2012, the blue, the last bar is all increasing. Urban, rural, for health and for medicine. Are people feeling more sick? Are more medicines being sold? But the long and short, or are the medicines getting costly? Next one, please. So, it's been shown this is the second commonest cause of rural indebtedness. 2.2% fall below poverty line because of out-of-pocket expenditure. And 50 to 80% estimates of denial of access to essential medicine. So I've underlined essential medicine, because just giving some medicine does not mean person is getting treatment. It has to be the medicine what the person needs. And 1/4 of the outpatients, there are figures up to 30%, some even quote up to 40%. Outpatient did not receive medicine because they could not afford. And NIN had done studies that in the prescriptions that are written, that if there are 4 or 5 drugs, that many, that time it was, I think, 30% could only buy the top 2, 3. So even the prescription writing the most important drug on top was so important. So if these medicines that you really need to be given priority, and also made affordable, they also have to be prescribed. Next one, please. So, healthcare and the drugs is a market. I'm underlining market. And it's a distorted market. Globally, there's increasing pharmaceuticalization of healthcare. And Dr. Havden Mahler, 1978, if you read Alma Ata Charter in 1985, the WHO had organized this international consultation of experts on rational use of drugs. And the first time, they had invited consumer and health activists also. This is 1985. 1986, World Health Assembly, resolution of rational use of drugs. Resolution of rational use of drugs. And US voted against rational use of drugs. We were horrified that why would anyone even vote against rational use of drugs? Why should there be irrational use of drugs? Anyway, he had called increasing pharmaceuticalization as a solution to healthcare problems as neo-colonialism. I'm quoting Dr. Hafdan Mala, whom I knew personally. So India is the pharmacy of the world. See, we are proud. We are proud that 80% of antiretroviral and many other drugs go from India. You know, we are, I think, third largest in terms of volume and 10th in terms of value the drug industry, public, private, whatever, is in this thing involved. And the antiretroviral drugs are bought by UNITAID, UN bodies, UNICEF, etc. And they are going, a large amount basically go to, you know, what are considered well-regulated markets. So when this thing is said that our drugs are bad, substandard, etc., you know, some propaganda is made about that. So one has to also see what is exactly happening. So our market is of 1 lakh crore. It used to be, I think, 10 crore when we became independent. But you know, very few, like what you call new chemical entities, really new drugs are not so many. A large number are, you know, what you call Me Too drugs. So you've got different brands of the same kind of product. If we are pharmacy of the world, how come that the medicines for the poor are not available when the diseases of poverty are increasing? And we say we have double burden of disease, of communicable diseases and non-communicable diseases, underlying which is the malnutrition. You know, it's a shame that why should India, about, you know, 40 to 49% of our children should be malnourished, and so many of them stunted, issuing, you know, chronic hunger. And I mean, there are big, high figures. I think 33% or something of mothers where body mass index of less than 18.5, which means chronic hunger. Of course, they're going to have a low birth weight baby anyway. So I'm saying food as a determinant of health and medicine, we can see the fate of both. So anyway, the national list of essential medicine, 348 in 2011. The new national list of essential medicine has come in 2015. It has 376 drugs. So we have 7 lakh, you know, retail outlets. And Jan Aushadhi is more than 1,000, I think the correct is 1,066 or 600 or something. 3,000 is the target supposed to be, we've not met yet. And so if you see 1,000, okay, even make it 3,000. They're not 3,000 yet. And you see the retail outlets. So how the medicines reach people, that most of it is through the retail outlet. Next one, please. So the combination drugs, we have a large number of drugs which are fixed dose combination. I'm going to go fast. There's aggressive promotion of costly brand. So costly brands, which are many of them of fixed dose combination. So even if the Prime Minister says generic prescribing, the single ingredient generic drugs are few. And unless they are prescribed, they are not going to be, you know, given. And if the retail person is going to stock those drugs, which has the highest trade commission, you know, the essential drugs don't have a chance. So the rationality, public health, public interest against the market doesn't stand. They're absolutely, you know, inversely proportion to each other. Unless it is in a policy, all of them is ensured that, you know, the production is going to be of essential and rational drugs. And I call what are rational drugs are the drugs about which we've been taught in medical college. Because we have many drugs about which we've never heard, and some of them are not even sold in Somalia. I'm mentioning Somalia because those are totally unregulated markets. So, and the education, of course, we know from where the education comes. So there is a general market failure where pharmaceuticals are concerned. And I'm underlining this because if you leave everything to the market, and this is the access to medicine, and it's not just the access to medicine, but also rational use of medicine that it will take up. There is something called Uniform Code of Pharmaceutical Manufacturing Practices, voluntary code, came in 2015. We got invited for a meeting in July. Then we came to know it had come. Otherwise, most people don't even know it is there. It's not mandatory. And if the punishment is, you'll be removed from the association, of that pharmaceutical association. So now so I would say those of you who are young, enthusiastic, and like challenges and adventure, just see what was the baby food code had come in WHO, to regulate the commercial milk, which was, being given to mothers, them being made to feel that they didn't have adequate milk. So the code came. So we also have a law, IMS Act. But for pharmaceuticals, there was a IPMA code, but it never, at that level, for against unethical marketing, nothing has come so far. And this is the only thing that is there, and if you note, it is code. Next one, please. I'll have to go very fast because I've got only 15 minutes. This drug price control order is being notified under Essential Commodities Act. I'm underlining Essential Commodities Act. If under pressure of some people, Essential Commodities Act goes, the drug price control order goes. And if under pressure from anyone, National List of Essential Medicine is delinked from drug price control order, it will be very difficult to regulate the prices of medicines, because DPCO is the only tool to regulate the prices, and this is only of essential drug, because I'm going to show you that most of them are anyway out. So earlier on, the pricing, cost of pricing, it was cost-based pricing. I'll just show you the formula on the next page, not yet. And now it has been changed after 2013 to market-based pricing, and that is simple average of the brands which had more than 1% market share. So it's market-based pricing. And we'd already seen earlier that it's a distorted market. Next one. Okay, no, last line also. And then there is in the this DPCO 2013, that the increase will be based on wholesale price index for the Schedule 1. Schedule 1 is the National List of Essential Medicine. But for those that are out, all the decontrol one, there will be an increase of 10% annually. Now we say that why are you encouraging non-essential drug by making it more profitable? Next please. I don't know, in my 15 minutes I should, but the cost-based pricing, material cost, conversion cost, packaging material, and sorry, that packaging material cost MAPE is maximum allowable post-marketing expenses, which include state commission and excise duty. So that's the formula. MC plus CC plus PM plus PC, 1 plus MAPE on 100 plus 80. So this was the cost-based pricing. So if the API, the raw material and all costs increase, the thing would automatically increase. And we were saying, no, you don't just give the cost, that the profit amount and all should also be included at the different levels. So it had to be cost-based pricing plus to 100%, make it 200%, make it more. Change it now, please. Next one. So now the ceiling. I said this is just a ceiling price. Both ceiling price now, simple average price of the brands in more than 1% market share. So now here is the issue. When they say National List of Essential Medicine, thing under price control, only that particular dosage form and that strength is under price control. So if 500 milligram paracetamol is under national list, the 650 and all others are going to be out. So ultimately, large number of essential drugs of other strengths and dosage forms are not under price control. And also the chemical analogs. You all are young, so you won't be needing these drugs. But after a certain age, a lot of people are prescribed these drugs. That atorvastatin is included, but the other chemical analogs are not. So the prescription of other stuff. Next one, please. All other combinations. So if there's an essential drug list in the under the DPC or under price control, all the combinations are out. All other combination of that list of the national essential drug list are. So like two hypoglycemics, metformin and glimepiride, these are the only two oral antidiabetics are under price control, which have 10% of the market, say about 625 crore. 6,000 crore anti-diabetic market is out. So when people say, because of price control we are suffering, you can see that it's written 18% of drugs in domestic market under price control. Recent figures are up to 12%. Only 12% drugs under price control. This is the estimate of Pharma Track, that 86.6%, that means 72,730 crores out of price control. Next, please. So these are the pricing pathologies. What I'm going to do is, there is a proliferation, because I've got 5 minutes more. So there are so many brands, they all have different prices. The ingredient is the same. So that's why international non-proprietary name, with people are familiar, should be something that should get used. And so even in the retail shop and in the big hospitals, you see there's a big difference. Next one, please. So this is the example of Rajasthan. If you see that the second column, imatinib, and if you remember the Novartis case, the Gleevec. So under the average ceiling price of DPCO 2013, it comes to, for 10 tablets of 4 milligram, 2,133. Rajasthan is procuring it at 172 rupees. So the point that was said, the bulk purchase, which Tamil Nadu is doing and Rajasthan is doing, that with bulk purchase, you can cut down the cost a lot, And so if you go, this is about 1,230 timer, and amlodipine, amlopress, anyone who has hypertension would be using that. 23 rupees uska ceiling price, and they're getting it for 0.98. If there is a, please pointer, can help. Next one, please. I'm skipping this. So this one is also from Rajasthan. So you see this column of MRP, and the last column. So diclofenac, they say all the vultures have died because of the diclofenac. I doubt it, must be pesticides and other thing. Maybe some, I don't know who would be giving diclofenac. So 73 rupees for 10 tablets, and the tender price they're getting 1.79. They're not getting lowest tender from either udar. In Tamil Nadu also, they are ensuring quality. And I would urge those of you interested, look at the entire Rajasthan, their medical service, how they're doing, and also of Tamil Nadu. This is very detailed. You have to have the entire system in place. It's just not making it and getting it, that's going to be, ensuring that these drugs get. So the long and short of it, that people who have these problems get the drugs. The main thing is access, affordability to the state and affordability to the patient. And this is part of the free medicine scheme. Next one, please. This is the SDG 3. I am not reading the full bit, except the last bit of trade-related intellectual property right and flexibility is being used. Next one, please. This is the SDG goal. We feel very strongly about it because intellectual property right is a barrier for access and affordability. IPR is a private monopoly right, and that should not be forgotten. And the Indian Patent Act of 1970, according to UNCTAD at that time, was considered a model act where public interest and the inventors' and this thing interest was balanced. We have sort of amended it in 2005 to make it TRIPS compliant, that we have now the Patent Act with, patent for product. Earlier it was patent for process. It was 5 to 7 years patentability patent period protection. Now it is 20 years. 20 years you can't touch. I want to mention South Africa case. South Africa case is extremely important because the product was of one company, but it was 39 pharmaceutical companies that took South Africa government to court for trying to make antiretroviral drugs available to their citizens who were HIV positive. So when you say for public health, medicine should be available, and if innovation has been done, should it be kept in the storeroom, or should the patients get it? And if they are poor, they have no right. If you have purchasing power, you're going to be lucky to get the drug. There is this documentary called Fire in My Blood. I would urge those of you really enthusiastic to see what happened. It was the positive people who protested. So it was them, public health people, health activists, and many of the others who have a sense, of that health as a right. And so the 39 pharmaceutical companies had to back off. And that's the time from after apartheid, they just become independent. And so that means no qualms. If people die, no problem. But the profits should be maintained. So this is a very important case because it highlighted that. Next one, please. So the Doha Declaration on TRIPS and Public Health 2001 came after that. That if these are going to be barriers and people are not going to be able to get the drug, the WHO International Commission on IPR, Innovation and Public Health 2006, please read it, because this is linking more with public health, because it goes into trade and it goes into other areas, commerce and all. Imatinib mesylate that I was talking, that Novartis drug for chronic myeloid leukemia, Section 3D in our Indian Patent Act prevents evergreening and prevents frivolous patents. So that was used because the crystalline form of the imatinib, for which Novartis wanted another patent they already had for the anhydrous form, which was denied because they could not show significant therapeutic benefit. So this was Section 3D for preventing evergreen and frivolous. So the attack is on Section 3D, remove by big players. Can I show one more? No. Yes, please. I'm so sorry. Okay, this hepatitis C. Mr. Amitabh Bachchan, who had come here to Symbiosis, I saw in the thing, he had hepatitis B and he's a TB survivor. So from the blood contamination, he could have also got hepatitis C. But the drug of that, 2,80,000 per month. The antiretroviral of $10,000, dollars, which had come down to $360 because India had contributed to that. For this was the only compulsory licensing that was used. We've used it only once. And we have been attacked for having a bad patent act. Next one, please. So since I don't have a pointer, there are 1,001 patents have been given from 2010 to 13, and 2/3 of them are by foreign companies. So that 2/3 are by foreign companies. Before that, next one, please. But only 1% of the medicines have come. So 38 to 96%, this is the R&D expenditure. But sales of Gleevec in 2002 alone was $4.7 billion in 1 year. I'm not talking about the other. Next one, please. So the hepatitis C, Punjab and Haryana are giving, that pegylated interferon was a costly drug, and you have to give it with ribavirin. Now, sofosbuvir and daclitavir is being given less than 18,000 to complete the course, because the government is doing it. Next one, please. Okay. Now, so these are many other anti-cancer drugs which are needed. Many of them are under patents. And what I'll do is I'm looking at Dr. Jyoti, and I'll abruptly end. Thanking you all very much.
Dr. Meera, so sorry about this, but I know you're a dear friend and you're not going to hold it against me. But your enthusiasm is marvelous, and the research that has been put in, I know it's years of work that has gone into this kind of presentation. And I just want to tell you that the documentary you talked about, we have actually showed it to our students in college, So going ahead from here, we have with us Shri Alok Kumarji, Advisor Niti Aayog, who is going to talk to us about the government perspective on health spending in India. Inadequate, inefficient, with a question mark over there. Sir, welcome on stage, and thank you for being with us.
So let me, I think at the outset, let me thank Symbiosis for allowing me this privilege to address this conference. I'm really happy to be here, and I'm really happy to share about how we at the Niti Aayog are thinking about health systems in general and health system financing in particular. I would also, Srinath, Meera, Dr. Geeta Sen all have an advantage over me. And that advantage is that they don't belong to the government, and therefore they can freely speak their minds. And I, belonging to the government, will be held as an institutional view rather than a personal view. So let me, to make this debate a little bit more, because I saw the debate is, generally one side of the argument. The other side of the argument has not come in. So if you permit me, ma'am, to allow me to present my personal views and not necessarily be confused with institutional view, that would serve this seminar in a much better. Thank you so much. So while agreeing to the fact that the government spending on health is inadequate, let me also point out to this audience, look at how much Bangladesh spends as a percentage of GDP on health, 1.3%. We spent about 1.2%. How much does Sri Lanka spend? 1.4% of the GDP. Yet, in terms of the outcomes, Bangladesh achieves 5 years more of life expectancy. Sri Lanka gets 10 years or 9 years more than us. That is why I said that while our funding may be inadequate, there is no getting around the fact that it is also inefficient. And inefficient in both ways, both in the public spending sphere and on the private spending sphere. Now, think about how my households, how my patients, or how my public negotiates the health system in India, right? So I'm holding my heart, I am having an angina pain, I run to a hospital which may be not very near my home, but somehow I make do. The providers there say that you have to pay 5 lakh rupees. What do? Do I have any capacity to negotiate? None. Then therefore I end up paying, and imagine that I am bargaining one-to-one against the provider. I am not using a collective bargaining mechanism which would, so if I am a CGHS holder, which I am, I'm a privileged person in this society, the same procedure will cost me 1/3 of the cost of what it will cost a common citizen of India. But when I start talking of strategic purchasing of the by the government on behalf of the citizens, people start having problems with that. Because then they start saying, oh, but you could avail that privilege to yourself and to a set of 10% of the population which find private insurance mechanisms to pay their premiums and therefore avail those services, but you want to deny them to the rest of the population. I just can't understand why. That is point number one. Point number two. Now, think about a system. You are running a company or running an organization. You quadruple your investments over a period of 10 years. Your market share in terms of the number of patients coming to you actually remains still, or in many cases declines, right? You would say that there is something which is wrong, which is going on. And the answer to this question be put in more money? I think there is something which we need to take cognizance of. And if you look at the NSSO data, which I have looked at very closely, the 71st round data, barring 4 or 5 states, everywhere the share of outpatients in the public facilities have declined over the 10-year period. The share of inpatients, except one category of inpatient, which is institutional delivery, where why has it gone up? Because you are paying 1,400 rupees to the woman to come and deliver so you are actually incentivizing that person or that woman to come and deliver in a public health facility. Barring that, despite your 4-fold increase in investment in strengthening the health systems, what are the outcomes? And even in those health systems which are run very, very well, for instance, in Tamil Nadu, even there you will find that the share of outpatients have actually declined, the share of inpatients are almost flat or have declined. The question therefore then to ask is it not also, apart from increasing spending, there is some element which is missing? And unless you start hitting at that element, unless you start for asking more accountability from your public sector providers, merely pouring more money into that system is something which might be counterproductive. There is a recent paper, look at what we have not been even able to ensure presence, leave alone service provisioning. We have not been able to even ensure presence of our service providers at government facilities. We have absentee rates of varying from between 20% to 40% across states of the frontline service providers. Even if we are able to make the presence, what is their incentive to perform? So there were 2 studies, I will point that out to you. One was quality of mercy-strained quality of service provision, medical service provision in Delhi. I'm talking out of Delhi, between the public providers and the private providers. So this study used trained actors to act as patients and went to the doctors both in the publicly run clinics, and in the privately run facilities, some of which may have been licensed providers, and some of them may have been what we call as quacks, but they tend to perform useful service to the society. Now, the same experiment, and they found out that the government doctors did no better than, and many times worse than, their unqualified private sector counterparts. You would have thought that 10 years of NHM, there would have been a marked improvement. But guess what? 2015, American Economic Review, this is a paper by Jishnu Barua and his colleagues, including Karthik Mullidharan. And what did they found? Exactly the same. Which means that we are, even if we are able to make our providers to be present, or public sector providers to be present in the facilities, they don't put in any effort. It's not that they don't know, because the same public sector providers, the same study points out, the same public sector providers, when they work in their private clinics outside the office hours, they do better. They do decidedly better than their private sector counterparts. Which means that one of the things which we need to fix is the issue of incentive for how my public sector is actually providing these services. And unless we are able to track those outcomes, unless we are able to provide, an issue was raised about voice. What voice does my patient have in front of a primary healthcare doctor? What kind of does in social status, in economic status, in